second by DT. Discussion, all in favor, please say aye. Those opposed, same sign. It passes. Then we have 6 policies. And we have to deal with these one at a time. Somebody want to make a motion to approve, starting with the first one?
Move approval of the complex cylinder safety policy.
Is there a second? Hello. Discussion? All in favor, please say aye. Those opposed, same sign. MM 600 medication diversion prevention.
Move approval of the medication diversion prevention policy.
Moved by Dorothy and second by Rex. Dr. Hyde. Discussion, all in favor, please say aye. Those opposed, same sign. Okay. PC 900 practitioner house staff orders.
Move approval of practitioner and house staff orders.
There's something on that one that I wanted to ask about. Under house staff, doesn't it say there intern and residents? Well, see, about 5 or 6 months ago, because of various things that were always happening, what interns could do, what residents could do, I thought we had agreed to discontinue the use of intern with house staff. I thought we were going to call them first-year residents. Is my memory gone wacko? Yeah, I mean, Bill's telling me my memory's wacko, so. No trick. No,
If we need to, we can go back and just cross out intern and just take that.
well, that was what I wanted to make sure was okay with everybody else, is because I thought we had gotten rid of the use of intern, the word intern, in describing house staff. We didn't vote on it.
There was discussion.
But there was discussion, and we agreed that would happen. If that's okay with everybody, that's what we'll.
You want to move approval?
Yeah, we can
subject to
approval
removal
and
of
just.
that parenthetical. We'll just
Okay, all right.
remove it.
You want to,
Do we need to rescind that or just modify it?
We can just, you can just
Okay.
restate it with the.
All right, move approval of the practitioner and house staff orders with the exclusion of the term interns, and you can just use residents?
Well, I would just take out the entire parenthetical, just say house staff,
Okay.
because it's defined further in the procedure, I believe.
That's where it's defined at, because I didn't read the procedure.
I didn't either.
It's on the portal.
well, you and I will both have to look at that
I
then.
didn't look at that.
Okay, any,
It's under definitions, Dorothy.
Okay. And it defines it on the definitions.
It says practitioner, house staff, Roman number 2 on the definitions.
Okay, and what does it say?
Practitioner, house staff is a medical doctor, MD, doctor of osteopathic medicine, DO, podiatrist, DM, or dentist.
In PC 90, in PC
yeah,
901.
The credentialing process is determined by the medical executive committee and ultimately by the board of managers to assess, order, document, and evaluate all patients.
In PC 901, the procedure that goes along with it, house staff's defined, and it does say the interns and residents, so we need to also, we'll go back in and we'll remove intern from the definition of house staff. So we just say the residents who
Okay,
are
so
employed.
we won't be using the term intern.
that is my understanding.
That's interesting, and we're not taking out the use of that term, and we can take it
Unless
easily.
you folks feel otherwise at the medical staff level, that,
Call PGY ones anyway, so.
okay.
Yeah.
So we agree without a vote, that's sort of how we'll do it? Okay. So we've had a first and a second discussion we've had. All in favor, please say aye. Those opposed, same sign. Trudy, Nurse Peer Review Committee, do you want to say anything?
No, unless you have questions. Pretty much the changes were just grammatical.
Move approval of reporting to the nurse peer review committee policy.
Is there a second?
Second.
Second by Nick. Nick Generoso. You got that? Discussion? All in favor, please say aye. Those opposed, same sign. Laboratory Services and Guidelines Policy.
And that's the archival,
That's the what?
that's the archival of that policy.
We're organizing it.
Yeah, yes, ma'am.
Okay. Move approval to organize, lab service guideline policy.
Is there a second for that? DT? Got it? Discussion? All in favor, please say aye. Those opposed, same sign. Informed consent. I don't know if we need you to come up, but Tim, come on.
Okay. Move approval of the informed consent.
Okay. Is there a second for that? You got that?
I'm good,
All in favor, please say aye. Those opposed, same sign. Good work.
Thank you, members of the board.
Thanks, Tim.
No, thank you. I've heard a lot of work went into that. Okay, we have two things that do not require committee action. The first is the AMI program. And if I remember right, the last time I was here, you folks were being surveyed.
Good afternoon. My name is
Good.
Ian Goodrich, and I'm the Director of Cardiovascular Services. And this is Beth Reed, and she's our chest pain coordinator. And we're here to present our report on the Joint Commission disease-specific certification for our AMI program.
Do we have slides?
Hiram,
There we go. So we have our acute myocardial infarction program that was just surveyed in April of this year. It was originally certified in 2016, and we had a successful recertification survey. For the program, our mission is to improve the care of AMI patients in our community, and being certified by the Joint Commission helps us in that mission to improve the quality of our program. We are required to have at least 4 goals that we report to Joint Commission monthly, and these are the goals for our program. We look at door to initial EKG times in the ED, and those should be 10 minutes or less from arrival. Door to balloon times or door to intervention in the cath lab time, 90 minutes or less for our ST elevation myocardial infarction patients or STEMI patients. We look at first medical contact by EMS to balloon time in the cath lab, and our goal is 90 minutes or less for our STEMI patients. And then we retired a goal this year for pre-hospital STEMI activations by EMS, and we added a new goal for cardiac rehab since we have a new program here on campus. It's on site here at the main campus, and our goal is to have at least 50% of our patients that are referred for outpatient cardiac rehab to enroll and attend at least 1 class.
awesome.
This is an example of the feedbacks that we provide to our providers and to the EMS providers for the patients that go to the cath lab so that they can see what our door to balloon times and our first medical contact times were. And for this patient, door to balloon time was 29 minutes and first medical contact to balloon time was 47 minutes, which are very good times. And part of that is a result of the collaboration we have with EMS in our community. So that was one of the strengths that the surveyor noted when she was here, along with committed leadership and engaged staff and our community involvement in education, which we do so much of here at JPS. And then future goals for our program are consistent documentation, decreasing the time from STEMI EKG to intervention in the cath lab for our inpatients who have STEMIs, and then increasing referrals to our cardiac rehab program. Any questions?
No, I think you got,
Yes, it does. It does. They have, yeah.
say, Nick couldn't hear you.
So, EMS loves feedback, and they like to know what happens to the folks they bring in. And so I think this is a great tool with feedback to EMS, and contemporaneously, at times, some of the EMS providers will like to follow a patient into the cath lab and kind of watch the cath take place.
we, just thinking that through, we don't have any problem with the EMS folks being in the cath lab at all? No HIPAA things, no regulatory thing, not visitor type things, just,
I don't know the answer to that, Dr. Rose.
This in itself is great feedback. I mean, a lot of times they just drop them off and we don't know what happens.
I'm aware they're part of the patient care team. Because they're aware, even for a trauma presentation, they're in the room presenting part of the care team to give backstory about.
You know, part of the team that's.
I personally would feel the same way. It's just that we've had a lot of discussions about who can be in an operating room, who can do this, who can do that, and these are people that we do not contract with. I'm just throwing out there as sort of food to think about. Maybe the next meeting we can have a little more. But I personally would feel like if they can go in there and see what's happening, great.
I would think that you're right, that we just need to make sure that that is okay. We've got all the compliance issues and everything covered. And that somehow, if you're in there, that if I was a patient, would have some say-so who's monitoring what you're doing. So as long as those areas are covered, I wouldn't see any problem. But I don't know if anyone can tell us that today, what the rules are for that.
It would be nice to see and have guidelines for each, for the EMS team and for anybody else, for them to go in. I think it's an amazing, part for them to see what they started and how it ends.
Right.
You know, it's a learning tool. And I also feel that if they shouldn't be in there because you're not contracting with them, that there could be a problem. It could be tomorrow, or it could be 2 years from now, but you have to cover yourself to make sure that that doesn't occur. So I would like to see, that come back to the table.
Okay, point well taken. I should have just.
Okay.
Okay, well, good work,
Thank you.
is what I would say. Excellent. When do they come back to visit again?
That will be back in 2020.
Great.
Okay.
All righty. The last one I have is Laura. Here she is. Patient employee physician experience update.
Good afternoon, everyone.
Good afternoon.
I know. So this will be short. I'm here to share our most recent results fiscal year to date, and I actually have even a more recent update on our HCAPS results. But as you know, our organizational goals are reflective in our HCAP scores, which are inpatient unit, our CGCAPs, which is our primary care clinics, and then the ED, our ED-CAPS goal. And our fiscal year-to-date results, we are meeting threshold for our HCAPs, although I will tell you, right before I came in here, I actually just got the more recent results, and we're actually at the 75th percentile, which is really big for us. So every quarter, we have gotten better and better this year. So we anticipate that should continue. No reason it shouldn't. So that's good.
Oh, yeah.
We're making progress in all three of our areas. Our CGCAPS primary care clinics are at the 30th percentile, so that's just over threshold. And then our ED-CAPS for the ED is functioning at the 77th percentile this year, so top quartile for them as well. So far, year-to-date, we've received about 75,000 surveys back for those results that are reflected up there. We do continue to make progress in all three areas, and we're still doing observations with the physicians, observations with the nurse managers, and with the nurses. We are conducting a lot of work within our three buckets that I talk about every time we come here, the patient bucket, the employee bucket, and the physician bucket. So we're doing orientation with residents. We work with our leadership teams to help them understand their results, read them, read comments, and figure out what to do with those. And so based on that work, as well as everything else that the teams are doing, we are seeing results in all 3 areas this year.
Good.
Are there any questions?
Awesome work.
Thank you. It's good. It's hard work. I'm telling you, it's hard to keep it and maintain it.
Absolutely. It's nice to see it in the yellow and green.
I know it is, isn't it? We're very happy too. I was very happy with the latest HCAHPS results too. Wanda's going to be so jumping for joy, and she can't be here today, so I'm excited to share that with her.
Jumping for joy.
Jumping for joy. Other questions that you all have?
No, good job.
Thank you very much.
No, I think that shows what happens when sort of everybody works together in the name of patient care.
Yeah. All right. Thank you all.
Thank you very much, Laura. That's all I have here for open session.
Okay.
Unless somebody has something, we have a couple things in closed session that I hope won't take very long.
Should not.
Okay.
Yeah, no. Stop commenting on length.
These troublemakers. Okay. Gonna adjourn to closed session according to section 551-071 Texas Citizens Act. Thank you for coming. We're gonna be back on schedule now, I think.